Okay, good morning, everybody. I'm Laura Ferris. I'm a dermatologist here at UPMC, and thank you all very much for coming out. So this morning, I'm going to be talking about early detection of melanoma. So melanoma is increasing in the United States. So these are the cases of new cases of melanoma and projections out to 2015. And so it's predicted that 1 in 50 individuals will develop melanoma at some point in their lifetime. As you can see, melanoma is more common among men. We estimate that 1 out of 36 men will develop melanoma at some point than it is among women, but still 1 out of 55 women will develop melanoma at some point in their life. The mean age at diagnosis is 52. However, we see melanoma across all age groups. So the reason that early detection of melanoma is so important is that it is associated with increased survival. So if we look at 10-year survival, if we look at this top curve, which is melanoma in situ, the thinnest melanoma, or even stage 1 melanoma, starting to be invasive but still very early, we could see that most people are alive when they're diagnosed with stage 1 melanoma 10 years later. However, if we look at stage 4 melanoma, which is spread beyond the skin, beyond the lymph nodes into distant organs, we see that very few people are alive in 10 years. So as a dermatologist, I look at this with great optimism that I have the potential to find melanoma very early and to remove it, and then people will be cured. And so I think that our best chance at decreasing the death rate from melanoma is to find more melanomas at this in situ to stage 1 stage. Now, the reason for this is that melanoma grows in sort of a stepwise progression. So we can see this is melanoma in situ. It's confined to really just the very surface of the skin. With time, it becomes a little bit deeper. It starts to go into what we call the dermis, which is sort of that second layer of the skin. It may or not develop features that are risky for metastasis or spread beyond the skin, such as ulceration. Eventually, in most cases, melanoma will spread to the lymph nodes beyond the skin as sort of the first step of metastasis, and then it goes to distant organs. And it's really when melanoma spreads to places like the lung, the brain, the liver, that melanoma is a fatal disease. So we're really trying to get melanoma when it's in the top 2 images and not when it's in the bottom 2 images. Early detection is important because we know that for some melanomas, they're going to start thin but get deeper. And there's some that grow at a quick rate, and there's some that grow very slowly. But if we think about a person who has a very thin, a 1/10 of a millimeter deep melanoma, the probability that they're going to die in 10 years is very low. It's about 1%. Now, over the next year, that melanoma may be not very aggressive, not grow quickly, but there are some that are going to start to grow very quickly. So if we don't excise that melanoma within that year, and it's one of the more aggressive ones, the probability that it will be fatal in 10 years can be as high as about 37%. So we really see this as a window of opportunity to catch those more aggressive melanomas, those faster growing melanomas, and that we think that we don't want to miss that window of cure. So one way that we do this as dermatologists, I spend a lot of my days screening people for melanoma, looking them over head to toe, looking for moles that are suspicious, and that we can biopsy to see if they are early melanoma. So what's the evidence to support screening that? You know, in medicine, we like to have evidence to support what we do. Well, unfortunately, we don't have the big kind of studies that you see for breast cancer or colon cancer. So part of that is that there's less melanoma out there than there is breast cancer, for example. So you really need a large population to be able to show a difference with screening. But we do have some evidence. So for example, we know that a full skin exam in the 3 years, if you've had a full skin exam in the 3 years before you were diagnosed with melanoma, you have a decreased risk of being diagnosed with a thick melanoma. So for years, we're kind of operating with this type of evidence, although those of us who do screening really believe we are finding early melanomas and we're making a difference. Well, fortunately now we have a really nice study that we can refer to that really shows that screening makes a difference. And this was done in Germany. So actually one state in Germany called Schleswig-Holstein. And this was a screening effort that occurred in 2003 and 2004. So people who lived in this state in Germany who were 20 years or older were asked to participate in the study. And about 19% of the population in the state said, yes, I'm going to come in and I'm going to get skin cancer screening. There were more women, about 3 times more women than men who decided to participate. And unfortunately, we'll talk about that, but that's something that we see commonly in melanoma screening. The screeners all took an 8-hour training course, and almost all the dermatologists and more than about 2/3 of the non-dermatologists in the state participated. So people could either go to their primary care doctor, get a skin exam, and then if they found something suspicious, they would be referred to a dermatologist, or they could go directly to a dermatologist. Most people went through their primary care doctor because there were just far more primary care providers, and that's a better way to reach the whole population. And then if there was a lesion that was suspicious, it was removed. So about 1 out of 23 people who were screened had a biopsy done. And from this, they found 31,000 skin cancers. So that was about 1 skin cancer per 116 people who were screened. Not all of those were melanoma. Those also represented things like basal cell carcinoma and squamous cell carcinoma, which are other less deadly but still skin cancers. So what we can see is that this is the period in which these skin exams were taking place. And this box that says screen project is the number of melanomas diagnosed. And the solid lines represent the state in which the screening occurred. And then the dotted lines are surrounding states. And what you can see is that there were a lot of melanomas diagnosed. And the reason for this is that things were found that would have gone undetected without screening. So finding more is one thing. But these melanomas weren't necessarily late. These were early melanomas. So we talked about that stage 1, the melanomas that are thinner, less than a millimeter. About 90% of the melanomas that were invasive that they detected were less than a millimeter deep. So this is really what we're trying to do with screening. Now, even more importantly, finding them is one thing, but does it make a difference? Well, you can see that again, that box that says screen project is when the screening was done. All the time, this graph isn't the number of cases diagnosed, but the number of people who died from melanoma. So if you look after that screening was done, in the areas where this screening occurred, you can see that those lines are going down. So this slope down is a decrease in death from melanoma in the screened area. The dotted lines are surrounding areas, and what we see here is we don't see that decrease. So we really think that this is great evidence that screening actually saved lives and prevented death from melanoma. This is a map of Germany, and what we can see here is this state right here is Schleswig-Holstein. This is before the screening efforts occurred. The darker your state, the higher the mortality or death rate from melanoma. And if we look at after these screenings occurred, we can see Schleswig-Holstein got lighter. The death rate went down. If you look at all the surrounding states, none of them got lighter. So it really tells us that melanoma death rates went down, and really just in the state where the screening occurred. This is great. This worked out well for Germany, but we want to do this in Western Pennsylvania. So how can we make this happen here? Well, Dr. Kirkwood really saw this data and said, we need to do this here, and because we're part of UPMC, we really have the opportunity to do this. So we've put together a great team of dermatologists and epidemiologists and oncologists in the UPMC health plan. And the plan, the project that's been organized is that primary care providers within UPMC health plan are going to be trained to screen for melanoma, and they're going to be asked to screen all of the adults who are 35 years and older in their practice once a year. And then suspicious lesions, much like was done in Germany, will be referred to a dermatologist for further evaluation. And from this, we'll be able to look at the number of biopsies or surgeries on the skin that are done, any harm that came from this. Did it make patients more anxious? Did we have a lot of benign biopsies? But really importantly, importantly, we're going to be able to look at the thickness of the melanomas that are and the number of melanomas in the patients who are covered by the PCPs trained to screen versus those in the sort of the rest of the population. So we're hoping that this can start out here in Western Pennsylvania and then be rolled out, more on a national level. But we really want to show that this can work in the United States too, and in Pennsylvania specifically. The next thing I'm going to talk about is who gets screened. And as we talked about, melanoma incidence and melanoma rates are higher in men. More men die of melanoma, more men get melanoma. This is an ad that I ran across in a women's magazine that I was reading on a plane one time. And this is Jennifer Garner, who's a pretty young woman, saying that she is going to examine her skin monthly and see a dermatologist for screening every year. And I thought, I liked the message, but I'm not sure that this is the person. We're targeting women who actually tend to be pretty good about screening. And the people who I really want to see targeted is I want to see a man over 60 in this ad next time. So if we look at, maybe they won't sell as many magazines, but are we screening the right people? So if we look at who gets melanoma, who dies from melanoma, and then who chooses to get screened for melanoma. This has been shown in multiple studies. We've looked at this in our population at UPMC as well. So the average person who gets melanoma is 60 years old, is more likely to be a man, and is more likely to be Caucasian and to have a higher level of education or income. The people who die from melanoma are likely to be older. So the median age at death is 68. About 77% of people will be over 55, and over half will be over 65. More men, over double the number of men, will die. Having a lower education level is associated with a higher risk of death from melanoma. And then again, we still have most of the cases of death are going to be in Caucasians, although being of an ethnic minority puts you at higher risk of death should you get melanoma. Now, who goes in and gets screened? Well, when we looked at this in our population, we found that over 70% of the people who came in for screening were under the age of 65, but as you can see, more than half of the people who are dying are over the age of 65. About 60 to 70% of the people who came in to be screened were women. Far more than half of them were college educated or higher, and most of them are Caucasian. So melanoma in older men is a big problem. So we're seeing the highest increases in men over 60, and particularly of the deep lethal tumors. The American Academy of Dermatology operates screenings, and we do these nationally. And when we looked at it, men over 50 were only about a quarter of those screened, but were about 44% of the confirmed melanomas. So overall in these screenings, if we screened 1,000 people, we found about 1.5 melanomas. If we just looked at the men over 50 who got screened, we found 2.6 melanomas in the same number. So screening this group, we can really make a difference. Unfortunately, they're just not as likely to come in. To put that in perspective, the probability that a 60-year-old white man will develop melanoma in the next 9 years of his life is nearly 5 times higher than the probability that a newborn white male will develop melanoma over the next 40 years. Okay, so men over 60, over 50 and particularly over 60, very high risk of melanoma. Again, if we look at young people who tend to often be more interested in screening, one study showed that you had to examine over 3,000 people to find one skin cancer, and that's not just a melanoma, that's any kind of skin cancer. If they looked at people between the age of 60 and 69, you only needed to screen 25 of them to find a skin cancer, and you only needed to screen 170 people to find one melanoma. So people over 60 really need to be coming in for melanoma screening. What else can you do besides see your dermatologist or your primary care doctor? The great thing about melanoma is it's visible on your skin in almost all cases. So you have the ability to find your own melanoma, not when it's late, not when it's lethal, but at the earliest stages when it's curable. The way that you do a skin self-examination, and it's very easy to find this information, is it's very simple. You look at all your skin. So you get completely undressed, you stand in front of a mirror, and you look head to toe at all of your skin. You look between your fingers, you look under your arms, you look in hair-bearing areas. Just because the sun doesn't shine there doesn't mean you can't get melanoma there. You look everywhere. And you do this ideally once a month. And you're looking for things that meet these, not just A, B, C, Ds, which most of us have heard of, but we also have E, P, R, and U. So asymmetry, which means that two halves don't look like each other. Borders that are irregular. A color that is usually more than one color, although there's certainly melanomas that can be one color. A diameter that is greater than 1/4 of an inch, although that alone shouldn't, if it's right under 1/4 of an inch, you shouldn't just rest assured if it doesn't look right to you. Regression, these are areas where you can see that there's white inside this black area. Evolving, meaning this mole is changing. So it started out as a small brown spot, and now you've noticed that it's twice the size, it's irregular in shape, and maybe 2 colors. That change is a really important sign. And then I really like this one, the ugly duckling. So, you know, most of us have watched Sesame Street at some point, and you've seen one thing is not like the other. So if you've got a spot on your skin, and you say, I don't have anything else that looks like this, that's your ugly duckling, and that's a lesion that needs attention. So if you just stand in front of the mirror and something jumps out at you as prominent, that's something that really needs special attention. So also, you know, patient concern is a big thing. If somebody comes in and says, I'm really worried about this mole, I'm really worried about this mole, don't, you know, trust your gut instinct and, you know, go see your physician. And I take that very seriously when people come in. Melanoma can look like anything. So that's why I like to put this picture up here. All of these things look very different from each other. These are all melanomas. So how can we improve early detection? I think public education is really important. People can detect their own melanomas or find them on their loved ones. So we want people to see, you know, us early. So we don't want to see things that come in that look really bad like this. We want to see things that come in that are just that sort of atypical mole. And then the other thing is we want to improve detection, you know, by healthcare professionals with increased screening, but also some special tools. So I want to talk to you a little bit about technology that can improve melanoma early detection. So this is a dermatoscope. This is something that's been around for years, and a lot of dermatologists use this. If you see one of us in the office, you may find that we use this or something that looks like it. It's basically a handheld magnifying lens with a light source, and it lets us look deeper into the skin. We can see beyond that light that gets reflected off the top layer of skin and see structures that we can't see with our naked eye. And studies have shown that we are more accurate if we are trained and experienced in using this. These come in many forms. In fact, there's even one for the iPhone, and we often use this because it lets us always have it with us and also lets us take images and send them to our pathologist or put them in your chart if we need to. This is an example of what one of these images looks like. So the small picture is just a photograph of a melanoma on the skin. The big one is one with a dermatoscope. So as you can see, we can see features and networks of pigment within there that you can't see with the naked eye. And we can see cutoff of the pigment in certain areas. So this really helps us in making a better diagnosis. The other thing I'll mention that is out there, and this is now available, and you may have heard of this, it's a device called MelaFind. It was approved by the FDA about 2 years ago now to assist dermatologists in making a decision of whether or not to biopsy. This is multispectral, meaning it uses 10 different wavelengths of light and lets us capture images down to about 2.5 millimeters deep in the skin. So this was a study, we participated in a study here at UPMC of over 1,300 patients with 127 melanomas, as well as a lot of benign lesions. And we looked at MelaFind, which gave an output of either this is suspicious, it should be biopsied, or this is benign. So the sensitivity, which is how often was biopsy recommended if a lesion was a melanoma, was about 98%. So that's pretty good. It picked up most melanomas. The sort of downside of this is that the specificity, which is how often did it say this is benign, you're good, you don't need to biopsy this, when the lesion was in fact benign, was only about 10%. So that's actually fairly low. So this is an example of technology that has some promise, but also there's a little downside to it. This was written up in the New York Times that, you know, because there were so many false positives, it may not be particularly useful in the hands of physicians. So something to, I think, to know about. There's some promise, but we need to think about the downsides of it as well. Another technology that's under development that we've been working on as well is something called epidermal genetic information retrieval. So what this is it's actually just a piece of tape that can go over the skin and over the skin of a mole and lets us get genetic material from that mole. So as you can see, this piece of tape is on there, the mole is circled, and as you peel it up, you get a lot of the dead layers of the skin, which I thought, well, that's just dead skin. But if you really look at these black spots in here are what we call melanosomes. So they are from the pigment-producing cells or the mole cells. So what we get is actually genetic material that is expressed within the mole just from the very surface level of the skin. From that, you can amplify that genetic material, look at which genes are increased and which are decreased, and come up with what we call a signature. So some benign moles have these certain genes up and these down, and melanomas do the opposite. So this was studied as a way, could we possibly get some information about, very non-invasively, about moles to determine which ones are suspicious for skin cancer or not. So again, looking at those measures of sensitivity and specificity, in an early study on a much smaller set of lesions, this was found to have a sensitivity of 100%. It actually picked up all the melanomas, with a specificity of 88%, so better than that 10%. So a lot fewer benign biopsies. We're working on the next phase of this study to look at it in a larger set of lesions, and hopefully this may have some potential in cases when biopsy may not just be a simple option. Okay, so what about if we put melanoma detection in the hands of the patient? So it's already there with skin, with skin self-examination, but there are iPhone apps out there that we found our patients were telling us about that can say that they can help you to diagnose melanoma. So these were some that were out there, and we thought that it was interesting and didn't really know how these were developed. And so one of the projects that I did with a medical student last summer was to see how these things actually work. So we said, we have lots of pictures of melanomas and benign lesions. Let's get some of these and let's see how they work. So we tested these on 60 melanomas and 128 benign lesions. So we had lots of photographs of lesions that we knew if they were benign or malignant. And we said, let's see how good they are. Let's look at their sensitivity. How often do they say that melanoma is suspicious and needs to be biopsied? What we found is that for the first 3, they weren't so good. They missed anywhere from 30 to about 93% of the melanomas that we showed to these apps. Now, interestingly, one did pretty well, about 98%, but this was a much more expensive app, and it actually took the photograph and sent it to a board-certified dermatologist who said, good, that can be stay on, or bad, that needs to come off. So, I think that evidence was promising that maybe we'll have this ability to use technology to sort of get access to specialists in remote locations. The inexpensive automated things that anybody can go buy in an app store really are potentially misleading and dangerous. These are examples of melanomas that were missed by those smartphones. And so not everybody in here is a doctor, but I think most of us would look at these and say those look like they're concerning. It would be great if we had something inexpensive that gives us a quick option, a quick feedback. But the disadvantage is that there's really these are not devices that are regulated, that are tested, or that have to meet any quality standards. So, the FDA recently started a process to regulate these things, to say these can't just be marketed directly to patients who could potentially be harmed by them. Okay, so the last thing that I can't go without saying as a dermatologist is that preventing melanoma is always better than curing melanoma. So one thing that people always ask is, okay, I should be wearing sunscreen. What SPF should I be using? And usually the answer is SPF 30. That's going to make the most difference. If you go beyond it, you can buy SPF 70 or 100 sunblock, but 30 versus 70 doesn't make a big difference. And the fact is that's true when we look at people who use sunblock correctly. So if you are reapplying your sunblock every 2 hours and you're using about that much with each application, that 30 is good enough. I don't think most of us use it that way, and I'm pretty sure I don't use it that way. So this was an interesting study where they looked at what is the true SPF if you use these sunblocks at different concentrations. And so what we found is that this is an SPF 30 sunblock, and if we use it at a high concentration, it does pretty well. It has an SPF of 30. If we use it at half the amount, it's at about 15, and if we use it at a quarter the amount, which is what a lot of us do, it's really less than 10. Interestingly, if you look at these really high SPF sunblocks, yes, at these high concentrations, they're 100. That's probably way more than we need. But if we only use half to a quarter of what we need, we get between that 30 and 50. So I have now become an advocate of using high SPF sunblocks simply to make up for the fact that we're not using them correctly and using enough of them when we do use them. So in conclusion, skin cancer screening can save lives, and early melanoma detection improves survival, and we can all play a role in this. Particularly if you're for men over 60, or if you have a man over 60 who is a loved one, please get screened or encourage them to be screened. Technology may really improve our early detection, but it has to be tested, and we need to know that the methods that we're using are going to do more good than harm. And please wear your sunblock and examine your skin monthly. Thanks.